So, hey, Nyleen, welcome to the Healthcare Intelligence podcast. I'm excited to have you here to talk about credentialing. It's a key operation part of the business. It's the first step because if nothing is being credentialed, there's not much service to being rendered and being paid. So, we'd love to have you just share a little bit more about yourself and how you got into the space.
Yeah, Charlene. So it was so nice to see you and to really meet you at the AORN, bringing in the business side of things to the nurses. So that's really exciting. And that's kind of my goal, right? I come from the business side of things and I became the administrator of a surgery center and realized, oh, there's a lot of things that nurses know about all the clinical sides of things. But when it comes to the business side of things, I learned, nurses have a gap in their knowledge training of how to eventually become administrators and learn the business side of things, which includes RCM. And then, of course, credentialing and payer enrollment and all the things that has to do. So I'm excited to share that desire to teach our clinical staff business things as they grow in leadership. But that's how I got into healthcare about 20 years ago and ended up in credentialing and starting practices and doing them across all different areas of healthcare.
I just want to underscore that because clinical people, they're touching the key parts of, the first row. They're seeing how things are happened, from prior authorization, making sure eligibility is being captured correctly. Also, medical necessity are documented in place, right? So it's actually, if they know about these like rev cycle like best practices, it will save the practice a ton of headache down the road.
Absolutely, especially in the outpatient, even in the surgery center world and hospital where we have to report these metrics, right? And then they're all called different metrics depending on if you're a office, right, where you're doing MIPS, and then the hospital when you're doing the hospital quality reporting to CMS. When you're doing all of this and you're collecting the data, the nurses are getting the data. They don't understand how that directly reflects and affects the revenue cycle down the line. So bridging that gap, I think, is critical and will make for really good nurses to become administrators as well.
And when you talk about credentialing, can you just walk us through, like, let's take an orthopedic practice, for example. Like, what does that mean for someone who heard of that word, but maybe doing that, but have no idea how that concept actually lands?
Yeah. So first we have to define the word credentialing because credentialing is used interchangeably between credentialing meaning payer enrollment, which means enrolling a physician with a payer, Blue Cross, Aetna, United Healthcare, Medicare, right? All that is an enrollment process, and that is also called credentialing. Then there's another side of credentialing, which is membership and privileges to perform procedures, to perform things at a hospital or a surgery center. And that's a different definition of credentialing because that's credentialing and privileging. So essentially, it's verifying that the doctors can do what they say they can do. So as a credentialer, we're the first gatekeepers from the hospital privileging side, meaning we're checking that the doctors can do what they say they can do. And then the payer enrollment side says, hey, doc, I'm gathering those credentials. I'm verifying those credentials and I'm sending them to the insurance company to make sure that we can get paid for those services that you're performing. And so there's two different roles. A lot of in the industry right now, the industry is going towards merging these roles and calling them all medical services professionals. We offer at the national level, there's an organization at the national level that provides education and certifications for both kinds of credentialing. So medical services management at a hospital and then provider enrollment specialists as well. So it's really cool that there's all these nuances and all these things to know, not only to get a doctor practicing safely, but then getting paid for it as well.
And when you are helping a practice stand up that process, what tools do you use? Like, is it manual today? Is EMR helping out in any way?
Yeah, no, EMRs don't help out. So no. So when you start off a practice, right, you want to credential the doctor. Let's just say we're going to do the enrollment of an application. Unfortunately, insurance companies are not unified, right? So we have a portal that was kind of created and now recently just moved and being bought by the private payers. But you have this portal, right? It's called CAQH. And doctors have to put their portal in there. And it's a lot of work. So the first thing is you make sure the doctor knows his usernames and logins to Medicare and CAQH. And then from there, you can start working all of the other ones down. But yeah.
How do you keep track of the roster in case there are many providers?
Right. So provider enrollment, when it comes to credentialing, unfortunately, the ITs of the world can kill me, but the reality is there isn't a good system out there that is affordable, I would say, across the healthcare. There is certain platforms that have a module to do a kind of tracking system, but there's nothing designed for provider enrollment. There's just a tracking system because you just submit an application and all you have to do is keep up, like, did I get an answer from the payer? Did I renegotiate the contract? So like you have a tracking system, but unfortunately for provider enrollment, it's all spreadsheets right now. And then you have for actual credentialing member, like at the hospital, those we have databases and like special programs that work beautifully. We've got great credentialing softwares out there that really help us keep track of all these doctors.
And then I think you also mentioned, I know in your podcast, there's a lot of interesting stories happening behind the scene. Can you just give the audience like a couple examples on what could go wrong with credentialing?
Let's talk to a little bit, since we've talked a lot about provider enrollment, let's start with the billing side. So my podcast, we have a podcast, me and my co-host Shannon, we have a podcast called Credentialing Chronicles. And the whole premise is we spill the tea on the doctors you see. And so we don't do it to hurt the doctors, but really expose what's happening in healthcare behind the scenes. What we have found is now, after doing this for a year, we have found that unfortunately in every state, we are finding doctors who are committing billing fraud. How do you commit billing fraud? Is billing under somebody else's tax ID, billing for services you didn't actually perform, seeing patients in another state telemedicine without having license in that state. And so as a credentialer, right, or as a person in the office, one of the things we help prevent is billing fraud. And so when I tell you, can we find it? Oh my goodness, yes, it's all the time. Upcoding, saying you did something you didn't do. I mean, we just found a doctor in Connecticut who was letting an unlicensed person see patients in one office while he was billing for 2 locations. So if somebody knows what they're doing, we're going to help put processes in place. But the other side of credentialing, which is at the hospital, is truly, we are the gatekeepers because we are the first ones to see an application to allow a doctor to either see a patient or not see a patient. We're the ones checking those licenses. We're the ones saying, hey, doc, you haven't done this procedure in 5 years. Maybe, you really shouldn't do that procedure anymore. And it's happened to me. I've had situations where, listen, I was on the floor when a doctor got arrested for, indecent pictures found on his devices. I have been there when an anesthesiologist got caught with a needle in his hand. I have been there when a doctor, was arrested for a DUI. And you have to contact them and immediately tell them they must take action to do things. So these are all situations that we deal with in credentialing to help keep the patients safe. So we verify all this information. We make sure that the doctors get the help that they need. Sometimes they have to enter these programs, and doctors and nurse and PAs and nurse practitioners are sometimes under monitoring programs. And so who's monitoring these doctors and making sure they're safe before they see you as a patient? And that's people like us. And so we get to do all those investigations. Like, the doctor did what? Like, yes, they are humans too. But there are things that we can do to help them stay safe, but also help patients say, like, hey, these are a couple of suggestions. Don't see a doctor alone. Don't, check your bills. There's always things that we try to teach to say, hey, because this stuff happened, even though it might be the fallouts, this is what you can do to protect yourself. And that's the whole goal.
Yeah. I mean, I think it goes back to patient safety, right? That's why potentially
everything goes back.
It's in the first place, right?
Mm-hmm.
That's why quality program is being put there. We also hear a lot of cases where provider has like they say that they're OBGYN and a specialist, they may have a couple different MPI, and those credentialing often get insurance like tripped up, right? When they're billing under the two different things. How do you see folks manage navigate that effectively?
So it goes to the enrollment. So the problem is that when you have to enroll your practice NPI and everything gets billed through that practice, and then those doctors' NPIs have to be attached to the practice. So the only one ever billing out a claim is the practice. As long as the insurance companies have the physician's NPI, the problem is when it gets to the claim, they're mixing the two NPIs. You should only be billing, and that's why you have the whole reassignment of benefits. That's why you have the enrollment process saying, I'm attached to this group. It's when a lot of locums or a lot of people start attaching them to all these different tax IDs, then the insurance system goes a little wonky. Or you have billings companies or IT companies or HIM companies that aren't building the boxes appropriately to go on the HCFAs. So all these numbers are getting mixed up.
Yeah. And then on the insurance end, though, I think it can be complicated to keep track, right? If there is a practice with many different specialists, I mean, since you talked about multi-specialty practices, like what do you see there? Like, what's the best practices that you have put in place to help minimize that impact?
That is a very good question.
It's a hard question.
That is a very good question because it goes back to actually the tax ID. And then it's, just look at the tax ID. And fortunately, the bigger tax IDs with the most best contracts, right? And those are the ones that everybody wants to attach to. How do we say? Those are the ones we form with larger groups. To keep track, I have, if I knew the secret, I would tell you the secret. Honestly, other than really well organized and audits constantly to make sure that everything is written and have a centralized person that's in charge of it. Because what happens is, I know you're like, oh, I want to go faster. I want to have all the applications go out, meaning to the different payers and the mapping of each doctor. It's better if it gets looked at by like one main person before it goes to the payers to make sure, because everything from spaces to dots to lines matters on every single application. So keeping track of everything is just making sure everything is applied a certain kind of way to get paid a certain kind of way. It's, yeah.
Looking at denials. And even though we can track like things are done correctly, we see payers make mistakes. And we're like, yeah, it's a complicated setup. Like we can understand why there could be human mistakes on both ends. But yeah, I think it's right now it's just really making sure good processes are in place when the dates are expiring. Do that a month prior so you can keep doing the CPD code.
You have to have an expirable setup. Yes, you have to have an expirable setup, automated system. And that's why credentialing systems are in place. But the problem is that they're designed for hospital credentialing, not payer credentialing. So you have to which I'm going to actually be in the process of working this out right now for one of my clients, because I really want to come up with a best practice of like, how can we keep track of all of these things instead of it just being like a project monitoring system? Because that's what it ends up looking like.
Right. And you may want to store the PDF. You want to store the actual update somewhere, right? Yeah. So it may need more than a cell to store the file.
Right. Exactly.
And when you're like curious, since you work with a couple different practices, you see things probably from one end to another. When you work with a new client, what's the first things you start when you're auditing their practice?
Okay, so I start with all of their documents, which means if it's a facility, meaning their logs, their compliance logs, their minutes for their meetings, for their governing body minutes, right? MEC governing body minutes. And then I want to see their credentialing files. And I want to see their HR files. Those will tell me everything I need to know in 5 minutes. My last surgery center I walked in, I said, where's the credentialing files? If I only told you what I have found. I mean, no reappointments, no appointments, letters, maybe some give granted privileges for 2 years, some 3 years, random fellows with something else, CRNAs with anesthesia, with like doctor anesthesia privileges, not CRNA privileges. I mean, the list goes on and on and on. HR files, no competency, nothing. So all of that, in 2 minutes, I can tell you how the surgery center is going to run, how the facility is going to run. Right? Let me audit 3 files. Give me 3 files. Let me look at how you verified the education, how you keep track of your licenses. All of that tells me 2 minutes. It's like when I ask an application for a doctor, how complicated they make it sound, how many times they refuse to go into a portal, and how much they're trying to hide to rush me, or even their email address. That those 4 things and how they communicate about their application process tells me exactly everything I need to know about a doctor. So similarly, about for a facility, I'm just going to ask for your bones. I don't even care about the meat if the bones aren't strong. So if I have no foundation, I have no structure, no credentialing, no understanding. Does your staff even know what that is? That's it. From right there, that's how you have to start.
Yeah, and I think as you goes back to what you said, every state, it happens in every state, right? Because and I'm actually curious, do you see that in big systems too, or is this more of a private practice symptom?
No. So believe it or not, I mean, I would say the institutions that have it the best are academic institutions. Academic institutions have a pretty robust healthcare quality system because they're being monitored by, obviously more than just, an accreditation body. But rural health is the most difficult, right? Because they have the least access to resources. That's what I've found. And then you have everything else is really kind of in the middle. Credentialing, unfortunately, can still, as much advocacy as we've done as an organization, as professionals, to explain that we save the hospital millions of dollars by doing what we do. Unfortunately, it's not reimbursed or, I think, given the respect that it should have within the healthcare organization. But it's, looked as very needed, right? You need it. You need a department. You need somebody to check the doctor's credentials, and get them enrolled. But it's allotting for that.
I think it's similar to HR, right? All the compliance auditor role where they are there to make sure the system runs correctly, but people kind of take them as infrastructure. They take them for granted, and they may not know like the nuance of it. And when things go wrong, how badly can that be?
Exactly. Oh, it can go very, very, very wrong. You can hire somebody that doesn't have the right credentials. You can allow people to do things that they are not allowed to do, and it could end up in ultimate severe patient harm. When we just let anybody do anything, or anybody come into our ORs or our hospitals because we're desperate, because we just need a warm body, that's what leads to unsafe practices and things. And when I tell you, healthcare bad stuff is happening every day, it's like, no matter where we go, every day I find a new healthcare scandal or somebody practicing under a fake license. So, or doctors with a lot of skeletons in their past and you would never even know that, they had that problem before. So it's to me, it's the most exciting job.
We find them in the news way too later. I mean, I think if there's one thing you can share with like your peers, also working in the space, potentially in credentialing, most likely in billing and administrative roles, like what would you share with them?
That we help guide and help set the tone for the entire organization. What we allow to enter and what we help, the risk that we help mitigate, is what's going to ultimately keep a healthcare system open and afloat. Because if billing isn't done correctly, right, or it's billed incorrectly, or fraud, you have audits, or you get caught, that's going to cost you millions of dollars. It may cost you your institution. If we don't credential, check doctors appropriately, have an infrastructure for medical staff, or a system to hold physicians accountable when they perhaps don't behave appropriately at a healthcare institution, when we don't have any of these things, it can cause not only severe patient harm, but severe liability on any healthcare organization. So I always am the biggest advocate, like, We are there to ultimately protect patients, and we are just as vital as every end user, every last person that touches the patient. We are responsible for that. So it's that's all I would say is we need to be recognized and talk about what we do in every area of healthcare so that we can explain how we are so vital to saving a patient from potential harm.
Awesome. Well, Nyleen, thank you for coming and sharing your story. I'm sure many people will find it resonating, and if not, they should know about this and check their practice tomorrow.
I know, right?
Thank you again for joining.
I know, it's so exciting. So I love talking about it and I love teaching about it. And it's, I look forward to keeping in touch and seeing where life takes us.
Yes. And also, can you remind us the name of the podcast again?
Yeah, so my podcast is Credentialing Chronicles, and we're on all the platforms, YouTube, Spotify, Apple, all the things. Would love to have you guys join us and listen, and we'll keep in touch.
Yeah, awesome. Well, thank you for joining, Nyleen. I'm sure we'll be in touch very soon.
Okay.
Okay.